of MTHFR genomic testing will be very useful in understanding our test. Before we begin, I have a few quick announcements. All callers are currently placed in lecture mode to avoid interruptions during the presentation. To submit a question, please click on the Question tab, and at the end of our presentation, Dr. Briggs will address the questions submitted. This presentation is being recorded and will be available on our website at www.spectracell.com in our Clinical Education Center. The slides will also be available for download on the site. We are pleased to welcome, for the first time, Dr. Bridget Briggs. Welcome, Dr. Briggs.
Hi, good evening. It's a pleasure to work with you guys tonight to just review some very interesting genomic tests that's become available through SpectraCell. And tonight we're going to focus on not only reviewing some of the biochem of MTHFR, but basically who should be tested, what the symptoms and the signs of a poor methylator might be, and how it relates to glutathione. So this is really called a single nucleotide polymorphism. We joke in the clinic that we call it, those of us who have the MTHFR polymorphism, we're mutants, and patients get a giggle out of that. So we all need to see that this is a very common polymorphism, and this genomic study has been widely underutilized, and really any patient who comes in with some form of a chronic disease, this is something that you really want to consider testing for. MTHFR mutational effects have a relationship to individuals who have high homocysteine, various mental disorders from ADD, PMS, bipolar, fibromyalgia, chronic fatigue, individuals who show skin deficiencies, hair problems, brittle nails, fissured tongue, geographical tongue, or cheilitis on the sides of the mouth. Many individuals who have varicose veins, spider veins, cherry hemangiomas throughout the body. Individuals who have hypercoagulopathies and infertility. Many different types of hormone imbalance, from testosterone levels that are either elevated or high in men and in women with PCOS, all kinds of problems with acne and endometriosis and fibroids with menomenorrhagia, a very common presentation with women with MTHFR. There are other relationships with people who just don't tolerate certain medications or oral agents like coffee, tea, chocolate, and alcohol, since they are also metabolized with methylation. Exacerbation of menopausal symptoms with women who either take hormone replacement, and talk about like breast tenderness post-beginning hormones, since they don't metabolize that estrogen either. And lots of problems in detoxification, which can be seen with elevated uric acid levels, and dysbiosis of the gut, which can be seen by high ammonia levels and all kinds of leaky barrier. There's lots of associations with this mutational defect in various cancers, especially colorectal cancers, breast cancers, and other cells that come from the lineage of adenocarcinoma cells or adenocarcinoid cells. These patients often struggle in estrogen dominance. They often struggle with hyperinsulinemia. Many of these patients are very sensitive to environmental xenoestrogens as well, since they impair methylation further. This is a view of the complexity of the biochemical pathways that are involved in methylation. If we just try to simplify the essentials, we know that methionine, which is just an amino acid that comes from things like eggs, it's got a sulfur group in it, so we know the eggs have that sulfur smell when they go rotten. Methionine is an essential amino acid that is ingested through the diet. It goes through this circle leading to homocysteine with the involvement of folic acid and B12 in the methylated forms. And one of the byproducts of this pathway can be seen as ammonia, which is why we talk about some of these individuals can have higher ammonia levels if they're going through poor methylation pathways. You see that the two amino acids involving tryptophan, which synthesizes serotonin, and tyrosine, which synthesizes dopamine, are heavily affected by slow methylators. So we can see problems with serotonin production and dopamine production, leading to mood disorders and gut motility disorders. And at the center of this all is this critical little nutrient, which is methylated folic acid, or 5-methyl tetrahydrofolate. A lot of the supplements that can be very useful in this pathway are very simple building blocks, from methionine to SAMe to methylated B12, 5-formylfolate, 5-methylfolate. Homocysteine requires both phosphatidylserine and trimethylglycine. So supporting this pathway is really very, very simple. This is a more simplified picture of the folate cycle and how it connects to the ability of the body to synthesize glutathione. And in essence, if you are a poor methylator or a poor cycler of folic acid, you therefore will be a poor producer of glutathione, which is, of course, the master antioxidant of the body. So the enzyme that we're looking at, the MTHFR enzyme, helps the body convert the prefolate into 5-methyl tetrahydrofolate, which is really the active form of folic acid. And 5-methyl tetrahydrofolate, for the rest of the night, we're just going to call it methylfolate. It is required, number one, in the brain, since folate does not cross the blood-brain barrier. Only methylfolate crosses the blood-brain barrier, so there's a huge critical need in the central nervous system. It interacts with B12, creating methyl B12 with the enzyme methionine synthase, and this converts the amino acid methionine down a complex road to homocysteine, and can either swing back in the circle from methionine to homocysteine, or has a secondary pathway, which is where glutathione comes into play. And homocysteine, in the presence of serine and B6, eventually produces glutathione, which is, again, the critical antioxidant in the body. MTHFR, this is an enzyme that irreversibly produces 5-methylfolate from the precursor 5,10-methylene tetrahydrofolate. It is used for de novo thymidine synthesis in the 5,10-methylene tetrahydrofolate precursor. So this is important for DNA synthesis, RNA synthesis, and so on and so forth. And this is why drugs like methotrexate can inhibit cell division if you begin to poison the folic acid. The derivative, or the metabolite of the methylene tetrahydrofolate, which of course is the methylfolate, is used to balance our homocysteine methionine conversion using B12 with it. Now there's another sneaky route around MTHFR. So those of us who find MTHFR polymorphisms, we know that the liver has this folate-independent enzyme called betaine homocysteine methyltransferase that can actually metabolize homocysteine to methionine. Most MTHFR mutations, the 23 that are known, most of them revolve around either the C677 enzyme or the A1298 enzyme. But this is kind of a biochemical picture of the enzyme, MTHFR, which has two chains, and I call it the C chain and the A chain. So it's made out of a dual protein, and it almost has the shape of what I call to my patients like a teeter-totter. So imagine a teeter-totter has two binding sites, which are the two children that sit on the seats. So one of them is NAD and the other one is FAD, or basically B2 and B3. And when B2 and B3 sit in the binding site, it activates the enzyme to convert B9, which is folic acid, to methylfolate. And then the methylfolic acid turns on B12 to methyl B12. So even a B2 and a B3 deficiency can create sluggish performance of this enzyme, and even a folic acid deficiency can create or mimic polymorphism in MTHFR. So here's your B2 and your B3 that kind of help the enzyme kick in. Now about 30 to 40% of Americans are found to have either a single polymorphism or a double. There's a lot of ethnic variability, and you'll see this enzyme polymorphism is found frequently in Mediterranean individuals, Hispanic individuals, often Pakistani and Indian individuals, and then Caucasians, and then less so in African Americans, and less so in Asians. The higher frequency is going to always be found in your chronic disease patients. So several chronic diseases have been linked in the literature, from patients with autoimmunity, gut dysbiosis, inflammatory bowel disease, individuals who have chronic recurrent mononucleosis, shingles, herpes zoster, cancers, hormone dysregulation, and so on and so forth. Transsulfuration, which is the ability of the body to synthesize glutathione, again, is dependent on healthy methylation. So these sheep, they're only this color, white, when they eat appropriate sulfation groups from the grass. So without that, the sheep are a completely different color. Glutathione structure, again, reviewing some more biochem, is just 3 amino acids holding hands. So it's a glutamic acid with a cysteine and a glycine. Glycine, very abundant in the diet, which is also produced when serine converts into glycine, which is why serine becomes an important building block to synthesize glutathione. Cysteine, again, is part of that pathway from homocysteine to cystathionine to cysteine. So it's, again, a precursor from the methylation pathway. And then gamma-glutamic acid actually comes from the liver enzyme GGT. And the glutathione structure has this core sulfa group here at the center, which is able to grab toxins and help with recycling of antioxidants and detoxification. The transsulfuration pathway, again, is the conversion of homocysteine down through the pathway using B6 and serine to the intermediate cystathionine. Cystathionine is then converted to cysteine, which is the precursor to the synthesis of glutathione. Polymorphisms exist in the enzyme that do this conversion, called cystic beta synthase, and that is not a common polymorphism that is tested for, but it should be thought of if a patient has very high cystathionine and low cysteine on amino acid profile. So again, reviewing that folate cycle and its relationship to glutathione, let's review it again. We've got our enzyme MTHFR that's working on the precursor 5,10-methylene tetrahydrofolate, which first came from folate converting to tetrahydrofolate. That converts into the methylfolate with that enzyme MTHFR, which then joins hands with B12 and the enzyme methionine synthase to convert homocysteine back to methionine. Methionine can also enter into the cell through the diet or can just be recycled from homocysteine. Methionine through the intermediate SAM, also called SAMe, then into accidental homocysteine, creates homocysteine. Homocysteine can recycle back to methionine or go down to produce glutathione. MTHFR activity can literally be inhibited by dihydrofolate, which is a precursor from tetrahydrofolate, and it can also be inhibited by placing patients on SAMe. This enzyme is coded by chromosome 1 in humans, and like I said, there's several genetic polymorphisms, 24 or so, but the two that we're going to really talk and focus on tonight, and probably the most amount of literature on, is what we call the C677T and the A129AC polymorphisms. So let's do the C polymorphism first. This particular mutation is probably the most serious of the two mutations. We see that this enzyme is called thermolabile. And what happens is the body produces the enzyme just fine, but it tends to have a difficult time holding on to the FAD or the B2. And since the B2 keeps falling out of the binding site, remember that little teeter-totter site, it causes a thermolability of the enzyme basically melts, and then the body has to resynthesize the enzyme all over again. And since this enzyme is that rate-limiting step in the ability to produce methylfolate, we see these patients have about anywhere between an 18 to 22% production of active methylfolate if they have a double mutation. If you have only a heterozygote mutation, a single, you may still function at about a 50% or 56% rate. And if you're the wild type without any mutations, you function at a high rate of anywhere between 66 to 67%. Now, all of these are dependent on the overall healthy ingestion of folate. This particular polymorphism puts patients at higher risk for problems in glutathione synthesis. So obviously, they're not going to transsulfurate well. They're going to have higher homocysteine levels. We know that high homocysteine levels is connected to more strokes and heart attacks. It's a hypercoagulability factor. Levels should be brought down to a level below 8 in anybody that runs in a higher level. If you look at the world, most worldwide levels are around 6, but individuals who run definitely above 15 have a much higher risk for toxic damage to the endothelial wall. So homocysteine is known to reduce nitric oxide levels. It's known to be a vascular toxin, promoting plaque formation and literally weakening of the endothelial wall of the vascular tree, which can create rupture of plaques and blood clots, leading to more strokes and heart attacks. Again, low folic acid intake is something that I always want people to think about. The FAD cofactor, just never forgetting to replenish B2 and B3 in these individuals, because this enzyme also has those two cofactors that are critical, not just the B2 but also the B3. The presence, if you replace methylfolic acid in these patients, it literally helps to stabilize the B2 or the FAD in the binding site and promotes stability of the enzyme. So that's why the replenishment of the methylfolate seems to be so beneficial. Enzyme deficiencies here have been strongly reported in not only chronic diseases but several psychiatric problems as well, including a huge relationship to schizophrenia and bipolar. The A129A6 polymorphism also has the normal homozygous flavor, it has the heterozygous flavor, or it has the, wild type, the non-mutant. This is a very interesting polymorphism because we don't really know today why this polymorphism creates deficits in the flow of methylfolate. When we look at the enzyme, it's not thermolabile, it doesn't have a heightened release of FAD or B2, and there is no essential protective effect in the enzyme function when you replenish the methylfolate. So we don't really get this mutation yet, but it definitely does seem to be related to problems in the nervous system, especially methylfolate crossing the blood-brain barrier. So this has a lot more psychiatric associations with it. These patients often with this polymorphism do not have high homocysteine. So elevated homocysteine levels in the blood do not correlate with an obvious polymorphism. Many individuals have normal homocysteine levels in the blood. So let's review some other functions of folic acid. So we know folic acid, once it enters into the cell, goes through a number of intermediates. One is dihydrofolate, which you see as DHF on the diagram. Dihydrofolate and its derivative tetrahydrofolate feed one pathway, which is called the 10-formyl tetrahydrofolate pathway, which is important in purine synthesis, and also thymidylate synthesis through the intermediate dihydrofolate, tetrahydrofolate, making the 5,10-methylene tetrahydrofolate. So this is where cell division comes into play when there's a defect in the enzyme MTHFR. And this is where patients can show, in cell division like skin, hair, nails, gut. These are the cells that really begin to show problems in healthy healing, red blood cell turnover, which is why these patients will show high MCV. The cells, the fastest growing cells of the body seem to lag when they're not getting enough of these methylated Bs. The enzyme MTHFR, as I said, produces the methylfolate, interacting with methionine synthase, converting homocysteine back to methionine, and again, through the intermediate, SAMe goes back to homocysteine. And then, of course, producing our transsulfuration pathway, which is how our body makes glutathione or glutathione. Methionine synthase, which is abbreviated MTR, this is the enzyme that interacts with the methylfolate and homocysteine to convert homocysteine back to methionine. So this is how we regenerate methionine from homocysteine. This also forms part of the synthesis of SAMe. Now, SAMe biosynthesis is very important because SAMe, or SAM, has a number of cellular functions. One is it is critical as a methyl donator to the liver, passing the methyl group to COMT, catechol methyltransferase, so that phase 2 methylation in the liver or phase 2 detoxification is robust. SAMe also works critically in the central nervous system because it is critical in the conversion of norepi to epinephrine, so for appropriate energy in the morning. And it's critical in the synthesis of serotonin converting to melatonin. So individuals who have impaired MTR enzyme, methionine synthase, or impaired MTHFR enzyme, if they do not synthesize healthy concentrations of SAMe, they tend to have problems in phase 2 detoxification, especially estrogen detoxification, because of course estrogen is detoxified through methylation in phase 2. These patients also have problems in regulating their excitatory neurotransmitters and their inhibitory neurotransmitters. That is your catecholamines, dopamine, noradrenaline, and epi, as well as serotonin. So these patients have the mood issues. They get the bipolar. They get too much excitation and not enough inhibition. And if you replenish the methyl Bs and the methylfolate with some of the other methylators, you see that bipolar symptoms improve dramatically, schizophrenia behaviors improve dramatically, mental focus, brain fog, sleep patterns, anxiety, all of this can improve dramatically. So although we're going through a lot of biochem tonight, I really hope that all of you sit back and just kind of put yourself on cruise. And you know, this doesn't come in a day. It's not easy to remember all this biochem. You can always go reference it and look at it again. But really, I'm trying to make the connections for you guys to try to feel how so many different body systems can be disrupted by an imbalance in this one little polymorphism and some of the other enzymes that it interacts with. So methionine synthase, we don't have a blood test for this that's readily available to date. There are ways to get it, but to date, MTHFR is, a common polymorphism. We don't know about the frequency necessarily of the MTR mutation, but it's really this relationship between the methylfolate producing B12 into methyl B12. And this is why the type of B12 that is supplemented in a patient can either be highly successful or not have any effect. So when we replenish B12 in our patients, we always replenish methylcobalamin preferentially over cyanocobalamin, hydroxycobalamin, or adenocobalamin. Methyl B12 is the single most active form of B12, very critical in the central nervous system. Again, very critical in detoxification and in helping with the recycling of methionine and homocysteine and the folic acid into the methylfolate. Any type of deficiency in B12 will halt the entire system, just like a deficiency of methionine as the amino acid can create halts in the system. And then we do have polymorphisms in the MTR enzyme and also in the enzyme that reduces MTR, which is called MTRR. Mutations in this gene have been identified as underlying causes of methylcobalamin deficiency. This leads to high MCV as found on the CBC. This means the red blood cells are coming out of the bone marrow very fat, very enlarged. And when you start replenishing the B12 as the methyl B12 and the methylfolate, the MCV just normalizes, just like homocysteine comes down. Patients who have high levels of B12 in the serum often are these patients who cannot convert their cobalamin to the active methylcobalamin. So looking at high B12 doesn't mean the patient's on too much. They may have a sluggish conversion, which is why you need to change the B12 to a methylcobalamin form. So this is just a simplified view of this little enzyme, methionine synthase, kind of working here on homocysteine and that little sulfate group, and how that methyl B12 is going to help convert that homocysteine back into methionine, and it's going to lose that little methyl group to the methionine. Homocysteine is now without, and now it belongs to methionine. Now B12 is reduced from methyl B12 to straight B12. And now that methyl group is going to be swung over to the 5-methyl tetrahydrofolate, which, once it delivers it back to B12, reduces it to the tetrahydrofolate. So you can see how the two wheels keep each other spinning, which is why methylfolate is critical in the conversion of B12 to methyl B12 and a healthy MTR enzyme. So let's look at some research on methylcobalamin. It is the #1 cobalamin used in the treatment of several central nervous system problems, from peripheral neuropathy, diabetic neuropathy, high concentrations being found to be successful in ALS. It has a strong role in what we call biomethylation. It's an important role in the environment. It's produced preferentially by some bacteria. And in the environment, it is responsible for what we call the biomethylation of certain heavy metals. So you got to be careful about patients who have toxic methylmercury. And there are, tests that you can look for to screen for methylmercury. So it's not uncommon if you start methylating a patient who has a lot of mercury issues or metal in their body. I've seen one lady with a bullet wound in her leg, and I started putting her on some, methyl Bs, and she started complaining about her leg burning. So this is heavily involved in heavy metal detoxification, so it needs to be done very safely. It has been studied widely in sleep-wake rhythm disorders, and it seems to help in a number of sleeping dysfunctional rhythms. It is also used in megadosages in cognitive function disorders like chronic fatigue, stroke, depression, Alzheimer's, and other neurological diseases. What's interesting about high dosages of methylcobalamin is it actually reduces excess glutamate, which we know excess glutamate is high in inflammatory conditions where there's lots of white blood cell activity, and glutamate is responsible for a lot of calcium excitation, neurological death, and a lot of pain syndromes. So methyl B12 can help to reduce glutamate and help it to convert into GABA, which of course is one of our primary inhibitory neurotransmitters and helps to relieve pain and promote sleep. Methylcobalamin, as compared to methylfolate, actually has been shown to rescue motor neuron-like cell death in homocysteine-mediated exposure. So methylcobalamin might have more neurological protection than maybe even methylfolate. Now, one other enzyme that I want to review is serine hydroxymethyltransferase. And this is the enzyme that, again, we don't do a lot of testing for, but it is involved in this wheel of methylation, which is when we see the conversion of serine to glycine. And remember, glycine is critical as a building block in the synthesis of glutathione or thionine. So if we don't have this enzyme working and we're not synthesizing enough glycine, we are going to have problems in transsulfuration or glutathione synthesis. So it is tetrahydrofolate dependent, converting it to the 5,10-methylene tetrahydrofolate. So this is where we see the recycling of our precursors. So a defect in this enzyme can exhibit many of the symptoms that you see that are a problem in the MTHFR polymorphism. So some people, you have a strong suspicion they have an MTHFR polymorphism. They don't, but yet they respond beautifully when you start putting them on a bunch of methyl groups, and this is the why. So glycine, again, is produced from the L-serine. And so when you suspect that this pathway is slow or there's a polymorphism, you need to replenish phosphatidylserine or L-serine and potentially trimethylglycine or glycine. If you look at patients who have very, very high ferritin in the blood, we see that high ferritin literally activates this serine hydroxymethyltransferase enzyme, elevates it, and you start seeing impaired homocysteine remethylation because you're driving instead a different pathway of the thymidylate biosynthesis. So when I see patients who have really high ferritin and I put them on methylators, I can cut the ferritin in half in a period of 4 to 6 weeks, even in patients who have hemochromatosis. So it's a great way to take the stress off of high ferritin. And here's that little enzyme and how it kind of interacts again with our tetrahydrofolate and our methyl tetrahydrofolate. So we have serine, which is an amino acid that you can ingest. And with the little enzyme, serine hydroxymethyltransferase, making our little glycine to build glutathione, or glutathione. And then we have, as a consequence, tetrahydrofolate converting into the methylene tetrahydrofolate again. So again, we've got to keep things cycling. We can't spin the right side of the wheel without flipping the left side of the wheel back and recycling our precursors. So this is a patient, Nadia, who is 36 years old, Mediterranean female, who was a G7P1, so 7 pregnancies and only 1 successful birth. She had a history of a significant beta thalassemia and chronic anemia, and she had history of several ongoing chronic blood transfusions since she has the red blood cell destruction. She had undergone 6 miscarriages and 3 failed in vitro fertilizations. She had recurrent fetal losses at about the same 2 to 6 week estimated gestational age. Her ferritin was almost 1,000. The rest of her CBC was fairly normal, except for higher white blood cells and platelets because of history of transfusions. And her total bilirubin was elevated, and she has visible jaundice on physical exam. Now, I ran her MTHFR polymorphism, and she only had a single A129A. And I checked her for hemochromatosis, and she was negative. Now, this patient, although you don't typically see such sensitivity to infertility and high ferritin at a single A polymorphism, you have to put the clinical complexity of the picture together. She has rapid red blood cell loss, so she functions like a true homozygote. So we gave her some detox protocols. We put her on fish oil and some estrogen detoxifiers, and then right away I just started putting her on intrinsic factor with some methyl B12 and some methylfolate, and gave her a little bit of topical progesterone on days 14 through 28. She didn't really come to me to get pregnant. She was just coming in for her kind of like a well woman appointment. And within a month after the detoxification program, she was pregnant. She was concerned that she was going to miscarry like she always did, although she hadn't gotten pregnant in solo ever. She'd only gotten pregnant on IVF. And we continued her on her prenatal vitamins and her methyl B12 and her methylfolate. She ended up during pregnancy requiring less frequent blood transfusions and had her baby, I think the baby's about 9 months old right now, and look at her ferritin, it cut in half just by giving her enough methylation support, and her total bilirubin went down from like 5 something down to 3. This is another patient, Steve, who presented at about age 56 for his first clinic appointment with history of hypertension, lots of abdominal, irritable bowel symptoms, lots of paresthesias, numbness and tingling in his extremities, talked a lot about just ongoing muscle pain and this bizarre rash that he would get these little bubbles, these little kind of sub-skin or subcuticular nodules that he would want to scratch all the time, and he'd bring it to the head, and that would heal, and then he'd start getting others, and he'd always had this problem with lots of fatigue. And if you looked in his mouth, he just had the worst gingivitis. His mouth was just very raw. He was working with a dentist, a periodontist, to just try to get his mouth kind of cleaned up. He was on oral steroids to try to help. Now, he was a smoker. During his first initial lab workup, we found that he was an early stage diabetic with hyperlipidemia, very low HDL. He had very high muscle markers of 289. Ferritin, again, over 1,000 when you're supposed to be less than 400. And I ran his hemochromatosis marker, and he was a double mutation. He had very high liver enzymes, with the GGT being very high. So we knew he's under a toxic hit, borderline high homocysteine, and then we ran his MTHFR, and he's a double heterozygote, right? So he's got the heterozygote C and the heterozygote A, so I call us the California guys. I'm a California person. I got the double heterozygote, and we can be pretty dang symptomatic. I also did the celiac test to make sure he didn't have the genetic tendency towards celiac, and he was negative. Now, we began to treat some of the chronic diseases, addressing diabetes and cholesterol and the non-alcoholic fatty liver disease, putting him on some metformin and some statin drugs. But this is when I was very new into methylation, so I began him on about 800 micrograms of methylfolate. And I just asked him to kind of observe his gums and his skin. And right away, we started with 1 a day, then we increased to 1 twice a day of the methylfolic acid, so that put him on 1,600 micrograms, then we put him on 3 a day. And it seemed with every methylfolic acid tablet he took, his gums got dramatically better, his skin rash went completely away. And then we started giving him some additional methyl B12 with methylfolate, which is found in Symphora. And we started seeing adrenal glands just improving in energy, and his gums and his skin, just big turnover. Now, over time, we switched into even stronger dosages of methylators and started giving him some serotonin builders and some improvement in detoxification. And almost overnight, this gentleman came in with every single laboratory test improved. Now, I can't tell you that the labs improved because he took metformin, and I certainly can't tell you his labs improved because he took a statin drug. I think a lot of it simply was just taking methylated Bs. So his GGT went from 79 down to 41. His ferritin went from 1,000 down to 500. His A1C completely normalized to 5.8, and all of his muscle inflammation went down completely normal to 74. Ricardo is a 44-year-old gentleman who was coming to the clinic over a period of time, and he had diagnosis of cholesterol and blood pressure and thyroid issues, but he was always chronically exhausted. And when we drew a testosterone level, he was low for his age, right at the first test. His TSH showed he was not completely controlled on his synthroid, so we gave him a little synthroid boost, and he had elevated homocysteine, so we gave him some methylators, methylfolate, methyl B12, ran his MTHFR, and he's a single C heterozygote, no hemochromatosis, but kind of impaired glutathione production. So to me, 700s in the serum kind of show impaired methylation leading to poor or lower levels of transsulfuration. We gave him some heavy metal chelation approaches in combination with the methyl groups, because remember I said that methylation really helps chelate heavy metals, and we kind of looked to see, was he accumulating higher levels in the serum of mercury and arsenic and other heavy metals. And we know individuals who are poor methylators, they get a lot of heavy metal disruption. They don't chelate and remove heavy metal well, because glutathione or thione is critical in metal chelation. So what was interesting is, if you did a pre-provocative and a post-provocative study, we were able to clear all the heavy metals to normal. And his iron, again, iron saturation improved to completely normal. His ferritin went from the 700s down to the 400s. So when we're looking at ferritin diminishing, what we're seeing is improved heavy metal chelation and removal. So this guy did amazing on methyl groups and detoxification. Very, very happy gentleman who, on a very affordable program, maintained methyl groups, and his blood pressure completely normalized, his cholesterol completely normalized, his need for as much thyroid medicine completely improved. So if we go on to some other research, well, what about the amino acid methionine? Methionine is actually really recommended as a good supplement as well, because it's being used as something that inhibits angiogenesis, like something that might be used in cancer. SAMe also has been shown to inhibit, for example, gastric cell cancers if you put them in a petri dish, or colon cancer cells in a petri dish. So SAMe has this other secondary, very important role, which is it is the primary methyl donator to DNA methylase, which throws methyl stop signs on the promoter region of genes, such as tumors. If you have good methylators, you can put methyl stop signs on the promoter region of a cancer gene and turn off the cancer gene, while you do not necessarily turn off tumor suppressor genes. So the supplementation of SAMe seems to be able to discern where we should throw stop signs, like on cancer genes, but no stop signs on tumor suppressor genes, to keep the tumor suppressor genes turned on running after cancer and helping to knock out cancer cells. So we can see this very complex wheel has so many critical entrances into chronic disease and healthy detoxification and the ability of the body to secrete appropriate neurotransmitters such as serotonin and dopamine. We see that SAMe, which is critical as a byproduct of methylation, is important in detoxification again through the liver. SAMe is important in neurotransmitters in the body's ability to make melatonin and to make adrenaline. SAMe is important in turning off cancer, including turning off retroviruses, herpes, EBV, CMV. And then, of course, this beautiful enzyme called COMT, which is the primary methylator in the liver for methylation and detoxification in phase 2, as well as degrading your catecholamines in the central nervous system. Now, let's take the peak of estrogen, because we really want to know, how does hormones play a role here? So if we look here that, estradiol is the primary estrogen that, we look at for the strength of hormones. And estradiol is going to go to the liver, which I say is like a car wash, and it's going to first form what we call your 2-hydroxy intermediates. There's a 16-hydroxy, a 2-hydroxyestrone, and a 4-hydroxyestrone. Now, we ideally like to see our patients run down the middle pathway, because this is probably the safest metabolic profile, and this is where we like to use indole 3-carbinol to support phase 1, and the methyl groups in phase 2 for appropriate clearance of estrogen. And then we end up with our final metabolites, which are our estriol and our 2-methylestrones, which is the 2-methoxyestrone and our 4-methoxyestrone, which are easily either urinated out or dumped into the gut and detoxified through the bile acid system. So estrogen forms hydroxyestrone, forms methoxyestrones. Now let's look how this can get impaired. Let's say we've got some fertile girl making estradiol, and she goes through phase 1 just fine, making her hydroxyestrones, but she's got a delay in methylation, so she can't make the methoxyestrogens. This means your 2-hydroxys, 16-hydroxys, and the 4-hydroxys elevate, and these have been connected to breast cancer and excess cellular growth, so excess uterine lining causing menomenorrhagia, fibrocystic breast. And then what that can lead is to a backup of estrogen. And then, of course, all estrogen is formed from testosterone, so then you see a backup of testosterone. So this is your PCO girl. She's got high testosterone, she's got high estrogen, she's got impaired estrogen detoxification, and then we see poor methylators get all this dysbiosis of the gut, so then this unhealthy bacteria metabolize some of the metabolites of estrogen connected to glucuronidase, and then we see estrogen re-enters into the body, further compounding excess estrogen being found in the body. So this is Susan, who's a 49-year-old Caucasian female, presented with a recent diagnosis of stage 2 breast cancer. Hormone receptor was positive. She had had a partial mastectomy. She had history of irregular periods. She had recurrent shingles. She was intolerant of all these drugs that they use in young women who still have hormones, because she couldn't metabolize things like ferrostone due to headaches and constipation. She was clearly this estrogen-dominant girl because she had fibroids, she had had a history of heavy periods, lots of fibrocystic breast, no miscarriages, she G2P2. But even through all of this, her estradiol level, was 26, and she had a bump in her inflammation SED rate. Her CBC, basic labs, thyroid, chemistry, all normal. She had excessive vitamin D initially because she was trying to over-ingest. But her GGT toxicity marker was normal, glutathione was normal, and her polymorphism for MTHFR showed the double heterozygote mutation. I looked at cytokines in her labs, and her body was on fire. Lots of inflammatory cytokines produced. We ran her estrogen metabolites, and we see her 2-hydroxy looked pretty dang good. Her COMT, which is the methylator, was methylating her 2-hydroxy to 2-methoxy, but poorly. She was in the yellow. Her 4-hydroxy was off the chart elevated, and her COMT was not methylating whatsoever. She had unmeasurable 4-methoxy estrones. We're seeing impaired methylation, which is consistent with that MTHFR polymorphism. When we look at her overall estrogen metabolism, she had a balance of the 2 and the 16-hydroxy, but she had an imbalance in her methylation activity. And she showed great symptomatology with an excessive immune system that was turned on, poor immune regulation, recurrent shingles, estrogen dominance. And so our goal was to support her hydroxylation. We wanted to drive her down the middle pathway, giving her some indole 3-carbinol, and to eventually try to get rid of some of these hydroxys and support appropriate methoxyestrogens. And you can do that easily by supporting methylation. So we go back to, what are my methylators? Well, I know COMT needs magnesium to activate it. I know COMT needs SAMe to give the methyl group to clear the estrogen. We know SAM is made from methylfolate, binding with methionine, and so on and so forth. So within a short period of time, Susan did a little detoxification. We gave her some indole 3-carbinol for that phase 1 middle pathway, and we gave her some blends of methylators, trimethylglycine, methyl B12, and we gave her some serotonin builder just to help with these perimenopausal symptoms. And what we saw in a short period of time is she felt like a completely better woman. She had gone through all of this chemotherapy, all of this breast cancer treatment. She had really become down, exhausted, and as soon as you just start facilitating methylation, energy, motivation, sleep improves. And her husband was clapping, saying he had a sassy little wife back. So the other thing I really want you to remember is all these xenobiotics, all these xenoestrogens in the environment, they interact heavily with our 2-hydroxy, 4-hydroxy estradiol pathways. And so we really see that excessive xenobiotic exposure will delay further estrogen detoxification. So people that have a lot of exposure to environmental estrogens, PCBs, dioxins, if you look at their blood levels by some of these toxic studies done by Metametrics, you're going to see that these people have much higher hormone deficiencies. But the beauty is that methylation supports detoxification of both, and so does SAMe. So again, almost everybody benefits from methylation support because almost everyone has an excessive amount of things like PCBs and dioxins found in their blood serum. Anytime the body experiences some traumatic events or stress, we see that there is an induction of a downstream alteration in immune function by reducing our methylation pathways. So again, when you methylate, you're protecting those immune-related genes so they don't start activating all this inflammatory cytokine immune activity. So Gail, who was a 72-year-old woman who presented with history of hypothyroidism and hypertension and cholesterol issues, all kinds of disastrous menopausal symptoms. I mean, her vagina had all this lichen sclerosis, atrophic vaginitis. She had recurrent shingles, terrible muscle and joint pain. She'd had a hysterectomy for history of cervical cancer. So here you go. You've got this woman who's had human papillomavirus, these retroviruses that dig in and just become very dangerous in individuals who have poor methylation. Her ferritin was over 1,000. She was a carrier, a single carrier of the hemochromatosis gene, but she's the double C. And she has very high homocysteine, so she's looking more like your characteristic MTHFR polymorphism. Lots of problems with headaches and vascular problems and hypertension because, again, homocysteine is a vascular toxin. Cholesterol was off the chart at 287 with very poor HDL and very high LDL, poor diet, pattern B. And all of her inflammatory plaque markers are high. High LPA, LPPLA2, high D-dimer, fibrinogen. I mean, she's like a heart attack waiting to happen. Bioidentical hormone creams in the vagina did help. Estrogen detoxification and antioxidant function did help. Changing her diet, sending her to first-line therapy, putting her on plant sterols to try to get this cholesterol down, and natural red yeast rice with vitamin B3. Dropped her ferritin down to 456 with strong methylation support and antioxidant support. Homocysteine normalized to 8. She no longer had any herpetic outbreaks from that moment on. Cholesterol dropped over 50 points, and she found a rejuvenation of energy she hadn't known. So again, when we're looking at disease states that are strongly related to polymorphisms in the wheel of methylation. I would say to you, MTHFR is one mutational defect that is commonly found in individuals who have chronic disease complaints. It is not the only mutation that needs to be thought about, and sometimes the chronic complaint may make you think, despite the fact that they may not have what appears to be a serious MTHFR polymorphism, any of these chief complaints, you should try supplementation of the methylators and to see if any of these symptoms improve. So all patients who have low glutathione, leaky gut, food allergies, chronic viruses, higher than normal B12 levels, complaints with low serotonin and the inability to stay asleep, or they wake up at 2, 3 a.m. in the morning and they think, and they can't turn their brain off. Think methylation. High ferritin patients, hemochromatosis patients, blood dysplasia patients, any autoimmune patient. We have several patients who have focal sclerosing glomerulonephritis, which is an autoimmune disease that causes renal failure and kidney transplants. And if you start methylating these individuals, you completely can improve their GFR and help kidney function. So all autoimmune disease patients, I consider methylation support. Anybody with any gut dysbiosis, chronic yeast infections, and all patients with estrogen dominance or cancers, we think about methylators. There are several prescriptions out there. I've listed them for you here. There is a strong need for methylators. Unfortunately, many of these prescriptions are just ridiculously expensive. We can't get them for our patients. So if you're able, I like to grab prescription and utilize insurance coverage whenever possible. But again, be suspect. How many patients will come back and say that was a $200 prescription of Metrex? This particular mutation, I'm reminding you, please remember your depressed patients and your bipolar schizophrenia patients, because these are so easy to help. Be careful about combining methylators too fast with people that are on a lot of psych meds. Sometimes you have to reduce some of the psychiatric medicines before you start slamming people with methylators. It does help children with ADHD incredibly, helps people with colic, helps people with sleeping disorders. And our last patient is our little 16-year-old Rachel. Migraines, big connection here. A lot of body pain, stiffness. She thought she had post-traumatic stress disorder after falling in cheer. But really, she had this previous history of ADD and lethargy, and she really struggled to get out of bed every day unless she took her Adderall. She had lots of seasonal allergies, food sensitivities, lots of abdominal pain, all the hormone stuff with dysmenorrhea. And hormone problems. She thought she had PCOS as well because she had all the hormones of high testosterone and too much estrogen and low progesterone and severe anxiety, severe mood swings. She's a beautiful girl that, you know, wanted to get better but just really struggled in even getting to school every day in high school, and asked to take a 6-month leave because the anxiety and the fatigue were just debilitating. Well, we ran some MTHFR polymorphisms. She was a double heterozygote. Her, again, testosterone, DHEAS were too high. She definitively looked like PCOS. We did food sensitivity. She was gluten, wheat, dairy, eggs, yeast. We changed all the food sensitivity. She had a terrible leaky gut, which again is common in people who cannot heal and turn over the gut every 3 to 5 days because they don't methylate. She did have very large ovarian cysts. She had all of the symptoms of insomnia, anxiety connected to low serotonin, so we put her on some 5-HTP and some things to support GABA and some methyl groups, methylfolate, methyl B12, and some magnesium for the synthesis, again, and activation of COMT. And we gave her lots of antioxidants and tried to get some of this estrogen detoxification out of her body with some estrofactors. Headaches, magnesium, 5-HTP, and some N-acetyl support for the synthesis of glutathione. This girl was like overnight completely transformed. She sleeps better, her moods are better, she's back in cheerleading, she is a senior in high school today. Her periods, her acne, everything has improved. She's like, I feel like a brand new baby. I'm going to skip Chris. I'm going to remind you of one other very interesting connection that I found, which is the role in methylfolic acid and the relationship of its other Bs. You will find a lot of patients who complain of ringing in their ears or sensory neural hearing loss or tinnitus. And I hear this and see this time and time again in patients who have problems in the cycling of methyl Bs. So this particular gentleman that I had seen last was a gentleman who had gone completely deaf in one ear and had gone to the Hearing Institute. And the Hearing Institute said, well, we don't know, once you lose your hearing, there's nothing you can do. And he happened to come see me within 2 weeks of losing his hearing on the left ear. He also had recurrent episodes of shingles. So I was very suspect that maybe the methylations would help him. And within 2 weeks of beginning his methyl Bs, he has complete restoration of his hearing. And the Hearing Institute was absolutely shocked. They had never seen somebody go through they had done hearing tests. He was completely 100% deaf in the left ear and regained all of that hearing. So that concludes the educational aspect. I want to open it up for testing or questions for anybody that wants to review specific questions.
Dr. Briggs, we're out of time for the evening, but we have received a bunch of great questions that we will try to answer to the best of this. We'll forward them on to the sales reps and get them answered as soon as possible. But I just wanted to thank everyone again for attending the live presentation, and an awesome thank you to Dr. Briggs for this very informative presentation, and thank you to everybody that was able to join us live this evening. As a reminder, everybody will be receiving an email with the link to the recorded webinar along with the presentation slides tomorrow. Thank you. Great night.